All right. So this is another cataract surgery procedure. We've injected the preservative-free lidocaine. You can see that the iris the pupil is fairly well dilated, but not perfectly dilated. So I use epinephrine here. I like to use epinephrine if I don't have a perfect dilation. I think over the years it's really prevented pupils from coming down intraoperatively in the middle of the case. And then I inject a dispersive viscoelastic. I like to, as I said before, grasp the wound with a 0.12 forceps, and that I found really helps to stabilize the eye and prevent any issues with sudden saccades or eye movements during the case. I use a 2.4 millimeter keratome blade to make my main incision there, and then I use a cystotome to start the capsulorhexis. We then complete the capsulorhexis using a Trotta forceps. And you can see just really using that 0.12 forceps really helps to stabilize the globe, and it really takes the stress out of this part of the procedure. I know for many surgeons this can be the most stressful part of the surgery is the capsulorhexis. If the capsulorhexis does not go well, then the rest of the surgery sometimes will not, it takes a lot more effort to get the rest of the surgery to go well. Height of dissection, I'm tenting up the anterior capsule before I inject. There you see a nice fluid wave. I push down to decompress the capsule bag, and then I hydrodelineate. I make a small movement to see if the lens is moving or not, or rotating. I'm not so sure that that movement is quite necessary. And then I go in with the phaco probe, and I basically core out a central area of the cataract, of the nucleus. And I'm going to use that to then do phaco chop. I switch to burst mode. I take my second instrument, a chopper, and I reach around the equator, and I pull the chopper towards the phaco probe. And then we split the nucleus nicely in half. Then we go on and continue that motion. You can see it's a very efficient maneuver. And then we remove the quadrant. So then I rotate, and you can see it rotated nicely, even though what looked initially with height of dissection, it wasn't going to rotate. I think as soon as you get the phaco probe in there and the fluid's moving, things will start to rotate and loosen up, especially once you remove that first quadrant. I pick up and remove other quadrants here as we move along, and then you can see also I'm manually moving around the phaco probe to get some better purchase. I'm manually using, let's see here. So in any case, we've removed the epinuclear plate, we've removed the lens, the nucleus, and there's very little in the way of cortical material. Sometimes when I don't see a lot of cortical material, I'll just go in with this instrument here and polish the posterior capsule centrally. And then we will fill the anterior chamber with cohesive viscoelastic. We use the cohesive viscoelastic because that makes it easier to remove once we have the intraocular lens in place. You can see here a really nice view, and cornea looks clear, posterior capsule looks clear. And it's at this point in time now that we're ejecting the lens. I use a wound assist technique. Basically the wound is, we're going to use the wound to deliver the lens. And then I use a single piece hydrophobic intraocular lens. I'm going to use this here instrument to free up the optic, and I don't have to wait for it to completely unfold, but I just want to make sure that they're not touching, and that way we're able to proceed. Let's see here. So gone in with the IA, and we're at this point in time, this is the first time we're introducing the irrigation aspiration handpiece into the globe. So we want to make sure that we do a good job removing any cortical material that's still present in the fornix. And that's why we're rotating the intraocular lens here. We want to rotate the intraocular lens so we can make sure that we free up any remaining cortical material that may be in the fornix. And we'll take our time doing this part. We want to do a good job. We want to make sure that we clean everything that's possible to get out in a safe manner out. I use the second instrument, the Charvel, to help me look if the pupil isn't completely dilated. And you can see there's some small cortical material there. And so I use the Charvel to retract the iris, and we remove that remaining cortical material that's there. Sometimes it can be quite stubborn, but I think it's good to be patient and remove this from the globe. And that's really, what this video is showing, is using this Charvel second instrument to retract the iris. And then here I'm using probably a Conner wand to retract the iris and look sub-incisionally, make sure that there's no residual cortical material there. And then here, all I'm doing here is just rotating the intraocular lens some more. The haptics, because the haptics are at the fornix, the haptics help to free up and loosen any remaining cortical material that's present there. So then we're doing we're hydrating the wound, hydrating both wounds. We see there is a piece of the cataract still in there, so we want to go in again with irrigation aspiration and remove that. And here we go again. We're hydrating the main wound. And once you'll see there's some air bubbles that go in with that. Those are gone by post-op day 1. I don't really make a big deal of trying to remove those. Sometimes if you're going to recheck your measurements using or intraoperative aberrometry, then I'll want to go ahead and remove those. But for the most part, I'll leave those in there, and they're gone by post-op day 1. We'll check the wounds, make sure they're nice and watertight. We'll apply some pressure on the globe. Make sure the wounds remain watertight. About it. So that is another case of cataract surgery. And that's really all we're doing here is talk about cataract surgery, techniques for cataract surgery.